Good evening, everyone, and welcome to today's webinar on Unveil the Breakthrough Dual Power of Elobixibat, first-in-class pro-motility and pro-secretory properties for the treatment of chronic constipation in adults. Today, our agenda will be introduction by me. I'm Dr. Pragati Srivastav, Medical Advisor for the Recura New Launch Excellence Team at DRN. This will be followed by Dr. Randeep Sood giving his talk on constipation management, unmet needs, and introduction to Elobixibat. Next, we will have a talk by Dr. Mayank Kabrawala on the clinical trials on Elobixibat, Indian and global perspectives. Following this by the question answer session and vote of thanks. Chronic constipation significantly impacts the quality of life for many adults. The available treatments typically focus on a single mode of action, and this often leaves our patient with unmet needs, as these treatments may not provide the comprehensive symptom relief. Elobixibat, as a first-in-class bile acid transport inhibitor, stands out with its dual mechanism, both pro-motility and pro-secretory properties, which offers a significant advancement in the treatment. This webinar today will explore why Elobixibat represents a breakthrough in chronic constipation management, backed by clinical evidence that demonstrates its efficacy as well as safety in improving the patient outcomes. With us today, we have Dr. Randeep Sood. Sir is chairman at Institute of Digestive and Hepatobiliary Science at Medanta Hospital, Gurgaon. He has more than 30 years of experience and has established two large GI centers of excellence in North India, namely at Gangaram Hospital and Medanta. He has pioneered various treatment options in the field of gastroenterology, gastrointestinal cancers, and hepatic diseases. Sir has numerous publications under his name. We also have with us Dr. Mayank Kabrawala. Sir is the director at SIDS Hospital and Research Center at Surat in Gujarat. Sir is also one of the principal investigators at the Elobixibat Phase 3 RCT in Indian patients. He has been practicing as a consultant gastroenterologist in Surat for last 26 years and holds extensive research experience as an investigator in clinical trials involving ulcerative colitis, duodenal ulcers, and for Clostridium difficile. Sir has displayed his presence on a global platform by way of poster presentation, which have been delivered in global conferences like DDW, APDW, and EUS. I now hand over to Dr. Randeep to take us through his presentation. Thank you so much, sir. Dr. Mayank, we might require your presence, your talk first, as Dr. Radhir is still stuck in the traffic. So, Dr. Mayank, if we can have you for your talk, sir.
Yeah, hi. Yeah, actually, I don't mind taking over, but my talk is mainly based for the clinical trials, and I
Yes.
thought it should be subsequent.
I understand, sir, but our viewers are already there online, so we cannot ask them to wait for it.
Sure. So did you check with Dr. Sood? Shall I start?
Just, I'll just check with them. So just give me a moment. Sorry for the inconvenience to the audiences. Just give me a moment to clarify this. So sir is gonna join in another 1 minute. So I think we can wait. Really sorry for the inconvenience. Some technical errors and all, which you can't really work around. Yeah, Dr. Sood, yes, we were waiting for you, so you can start with your presentation now. Do let me know if there's any problem. We can share it from our side also.
Okay, shall I start my
Yes, sir. Yes, sir.
slides? Okay,
Yes.
I'll just share my slides. It's just taking a minute to open, and but you have not given me the rights to share. I don't have the right to share it.
So you will be having it. It
It's,
will be there at the down part, the green
no, it's
share
not there.
button.
No, that's why. Acha, okay, I know I have got it.
Yeah.
Yeah. Yeah. Can you see my slides?
Yes, sir. If you can just go on the
Yeah,
full
I'll
screen.
go full.
Yes, sir. You can.
So, good evening, dear friends. Are we on?
Yes, sir. Please continue.
Yeah, good evening, dear friends. I appreciate your joining at this time of the day when you all have finished your work and are exhausted from it. But this is an exciting event because this is introduction to a new molecule which is being introduced for in the clinical armamentarium of all the physicians and gastroenterologists in managing chronic constipation. This is Elobixibat, which is, as the name says, it blocks the bile acid transport mechanism in the terminal ileum. And I'll go through the slides to tell you how it is important, how it's different, and what are the advantages of this new molecule over what is existing already. So we will be talking about the complexities of the chronic constipation, how our present day medication is available, and how will Elobixibat, affect it, and how will it play a crucial role in managing patients with chronic constipation. And then, of course, we'll have a talk from Dr. Mayank Cabreval, who will be talking about various trials which have shown its efficacy. So when we talk of chronic constipation, it's a very, very common, ailment which people suffer from. And if you see that 15% of adults have chronic constipation, and it is accordingly sixth most common GI symptoms. In my practice, I have seen a significant difference in various populations in their symptoms of chronic constipation. And it is more often in females than in males. It is according to the Rome 4 criteria. Chronic constipation is defined if there is 2 or more of the following symptoms present for more than 3 months. That is, the most important is fewer than 3 spontaneous bowel movements in a week. In fact, Indian population wants every day, but definition wise, 3 is less than 3 per week. And if there are any of the additional symptom of straining, lumpy or hard stool, that's Bristol 1 or 2 stools, sensation of incomplete evacuation, sensation of anorectal obstruction, or person is using manual maneuvers to evacuate, like digital evacuation, etc. So when we investigate a patient of chronic constipation, we should look at 2 things. Is it a primary constipation? Is it a secondary constipation? Because primary constipation is because of the inherent problem in the colon. Either it's a normal transit constipation, that colon is moving at the regular rhythmic pace, but there is still constipation, which may be dietary, which may be habit regulated. Then there is slow transit constipation, where the colonic movements are sluggish, and we'll come to how we manage it. Then there are large proportion of defecatory disorders, where people actually feel that there is an organic obstruction in the when they are passing stools, and they use various maneuvers. They elevate their legs. They use Indian toilets. They use digital evacuation, and today we can diagnose very objectively this kind of constipation. However, we must not forget that there is this constipation due to other causes than the primary motility problem in the colon, which is the secondary constipation. It could be due to various medication, or due to anatomical alterations, or even certain diseases like diabetes, Parkinsonism, etc., and medications like calcium channel blockers, or even calcium itself. So I will come to that later. So when you look at the demographics of prevalence of chronic constipation, almost half of the patients have a self-perceived constipation. You ask a patient, what do you mean by constipation? They are perplexed, because some of them will tell you they are having, going 5 times a day, but they don't feel satisfied with it, but they still term it as constipation. There's another person will tell, Dr. Sahab, patli aati par wo khul ke nahi aati, and then person still terms it constipation. So you have to be very objective. Then 18% of patients will be straining at stools, and they will term it constipation. And almost 1/4 of patients actually term constipation when they are not satisfied with the amount or the number of stools they actually are comfortable with. And as I told you, it is more prevalent in females, 20% versus male, 12%. And 6 out of 10, that is 60% of the patients with chronic constipations have associated systemic comorbidities like diabetes, hypothyroidism, organic brain disease, or combination of these diseases. And in fact, various conditions which immobilize a patient and make them, less mobile is also a very important factor, like orthopedic problems, like neurological issues. And then 1/3 or 2/3 to 40% of the patients are regularly taking medicines which can induce constipation. So the one has to be very careful about this. So which are the factors which influence chronic constipation and its impact on quality of life? You see, chronic constipation significantly lowers the subscore of physical, emotional, and social aspects of quality of life. And factors which affect are a person, older individuals, particularly females, lack of physical activity, as I told you. If a person becomes physically active, many people can actually resolve their constipation by becoming physically active. And self-related health, neurological conditions like multiple sclerosis, Parkinsonism, etc. Depression, not only to depression, but various medication in the depression lead to constipation. And GI, cardiovascular, musculoskeletal conditions, and diabetes, which I mentioned earlier, or certain surgical conditions which slow the colonic transit or bowel movements, and medications like NSAIDs and aspirin, opiates, particularly cause constipation. So our treatment goals are, very well defined. Primarily, we want to improve the symptoms like incomplete evacuation and difficulty in passing stool, because you can, keep on convincing a patient with constipation that you're passing one stool a day, which is sufficient, but the fellow will be coming back to you saying, no, Doctor, I'm not happy with the way I'm passing stools. So you have to address that problem. Secondary goal is that you must, get the patient out of the definition part, that the passage of stool at least 3 times per week or more is our secondary goal, and the stool should be preferably Bristol 3 or 4, and they should come with minimum or no straining. And ultimately, overall goal is, by leaving this, to improve quality of life of the patients. So let's look at what we have already available to us and which we use day to day to treat our patients. So this is a summary slide that there are first line treatment bulking agents. Like we give Isabgol, we give bran, we give fiber to patients, dietary or pharmaceutical. And these are soluble or insoluble fiber. Soluble is better because insoluble causes more bloating. And how does it act? When it goes into the bowel lumen, it absorbs water, increases the stool volume, and softens the stool. So there is a propulsive activity, actually becomes more effective, but there is a downside to it. Because of the increase in volume, it also causes bloating in people, certain people. Second line, or many times is our first line, is osmotic laxatives, and most popular are lactulose, polyethylene glycol, or magnesium sulfate. They produce osmotic gradient in the bowel lumen, and this way they increase the water. They extract water from the intestinal lumen and hydrate the stools and make them soft. But again, some degree of bloating and abdominal cramping can happen in these patients. There are unpredictable actions. They can cause diarrhea, and if they cause diarrhea, they can cause electrolyte disorder, and particularly in patients of renal failure, etc., or cardiac failure, they can cause electrolyte disorders. The third lines, laxatives are the ones which cause irritation to the colonic muscle, and they stimulate it to contract faster. Bisacodyl, senna, rhubarb, and sodium picosulfate are commonly used. In fact, the most commonly used of these is senna in various forms, and of course sodium picosulfate. All these herbal preparations of Kayam churn and all etc. have some degree of these, and that's how they work. And they basically rely upon stimulant laxatives, and this stimulates the intestinal mucosa to secrete water and electrolytes, and also accelerate the peristalsis. So they have dual action, but predominantly they increase the peristalsis. Because of increase in peristalsis, they cause abdominal cramps. They may cause diarrhea and pain. And melanosis coli, earlier we used to be worried about it, but now it's known that it does not lead to any long-term consequences except for the change in color. But as I told you, that because of this, the diarrhea and pain, many patients are uncomfortable. The fourth and the recent ones which have been added but the secretagogues like lubiprostone, which acts on the intestinal calcium channels and increase the intestinal fluid secretion, and thereby increase the water content of the bowel lumen, and thereby softens the stools. But the biggest problem with lubiprostone is that it causes nausea and also anorexia in some patients, and occasionally vomiting and diarrhea. The biggest thing is that if you give it at night, person may have to get up in the middle of the night to pass stools. And then certain prokinetics like prucalopride, which predominantly act on the large bowel, and they have selective action on 5-HT4 receptors and increase the colonic motility. However, this is one laxative which is absorbed systemically and can cause headaches, nausea, abdominal pain, even depressive illness, and diarrhea. So one has to be cautious when one using prucalopride and know what are the possible side effects and where to use, where not to use. So, dear friends, we have quite an array of already existing drugs which we use for constipation, and we are able to manage large majority of these patients by either combining or carefully choosing according to the patient's symptoms, or or the motility studies which we now are doing more and more in advanced centers to give personalized medication to the patients. However, there are, this is the algorithm which is, ISG has also recommended that you have, chronic constipation, exclude drugs or organic cause, take detailed history and physical examination. If there are no alarm symptoms like anemia, severe pain, or occult blood in the stools, then you start, treatment with lifestyle modifications like increase fiber in the diet, increase fluid, and have increased by the gastrocolic reflux augmented by taking some fluid in the morning, then increasing physical activity, and then trying to train your bowels to go at a particular time, and that helps in large majority of cases. And if there's no pre-existing bloating, then we start with the bulk laxatives, or if there is bloating and patient already says there's a lot of bloating or gas, then we start with the osmotic laxatives, preferably polyethylene glycol, or at times magnesium, milk of magnesia, because that is very cheap, or lactulose. Some patients actually respond better to lactulose rather than polyethylene glycol, but this is individual for various patients. And if the bloating is already present, then we choose only the osmotic laxatives, or if they have good response, continue treatment. If no response, then we investigate the patient and subsequently decide what is to be given. And if there are red flag signs like anemia, like weight loss, or patient is elderly and recent onset constipation, then we must investigate it right in the beginning rather than giving medicines, do colonoscopy and relevant tests, and then we decide. And if there is a patient who has constipation and patient is not responding, then we have to decide which kind of chronic transit it is. Is it normal transit constipation? Is it slow transit constipation? Or is it fecal evacuation disorder? Then so we do that through various transit studies, or rectal manometry, or MR deficogram, and treat these patients as given in this flow chart accordingly. And most of the patients are managed in this way. However, there are certain advantages and disadvantages of various group of laxatives. Like you give lactulose, has a big problem of giving bloating, polyethylene glycol, again abdominal distension and diarrhea, and can cause electrolyte imbalances. And milk of magnesia gets absorbed. So we should not forget that it is one agent out of the three osmotic laxatives which can get absorbed. So hypermagnesemia is a real problem, particularly if the patient is having renal failure. So one should not use milk of magnesia in patients with renal failure. Also, my caution is that when you are dealing patient of cirrhosis and there is a possibility of HRS or patient is on diuretic, avoid milk of magnesia, because hypermagnesemia leads to obtended sensorium. And as earlier mentioned, sodium picosulfate is a very effective laxative. It's a stimulant laxative, but again, it is not recommended for more than 4 weeks of use. And it is also not very safe in patients of CKD. So one should avoid this laxative in that. And of course, prucalopride is very effective, as I told you earlier, headaches, diarrhea, and depression, suicide. And because it gets excreted by the kidney, CKD present can increase its duration of action. Similarly, in lactating mothers, we should avoid prucalopride because of its systemic absorption. And so one has to be very cautious about what are the side effects. So where do we, need something else apart from what already we have? So most of the patients are happy. However, almost half of the patients are not very happy with the medication we give them, because most of these act through only one action, either increasing the intestinal water retention or motility. So if they only increase the water retention, they cause spontaneous bowel movement, but they may cause bloating. And if they cause only bowel movement, so they can cause diarrhea and other side effects. Long-term safety again is a very important issue with all these, and particularly when there's comorbid conditions. So let's see what is new happening. Elobixibat is a new molecule. It is a partial intestinal bile acid transport inhibitor. So what it does is that the absorption of bile acids at the terminal ileum is blocked partially by this agent. So you have more bile salts coming to the colon. And bile acids, are laxatives. And they cause increased intestinal secretion as well as increased colonic motility. And this is how its evolution happened. It was approved in Japan in 2018 and has been under works for a long time. And it's a first-in-class IBAT inhibitor where the trials have also shown clinical efficacy. The biggest advantage is it acts locally in the GI lumen and does not get absorbed much. And it has a dual action. It increases the intestinal secretions, so increase the bulk of the stools, and also increase the motility, so thereby increasing the probability of a spontaneous bowel movement. We start normally with a 10 milligram dosage before a meal, and here practically before dinner, and then subsequently after 1 week, you try to give the patient maintenance dose. If patient is many patients are happy with 5 milligrams. Some people need continued 10 milligrams, but you never go beyond 15 milligrams. So this is the mechanism of action, which I will repeat, that it causes, inhibits the IBAT, that is the intestinal bile acid transporter, in the transportation in the terminal ileum. This leads to decreased absorption of bile acids back from the ileum into the bloodstream. So it interrupts the bile acid absorption. So and then this bile acids present in the colon increase the secretions and motility, and that increases the bowel movements, which I told you earlier. There are various mechanisms of action. I'll not go into the details. These again mention various sites where it acts, but I think that's this is not the forum at which we should talk in detail about it. The biggest advantage, as I told you, it's a locally acting drug, and primarily excreted, eliminated by stools, and only 0.01 is excreted in urine because it doesn't get absorbed much, and that's why it has got very little systemic action. There's very little drug interaction because it is not a systemic drug. So this also is important because there is no drug resistance and does not cause significant change in the gut microbiome, because it does not change the pH of the gut significantly. So just to reiterate, only less than 15% patients experience at least one adverse event, which is minor, predominantly diarrhea. And dose titration can be done according to the patient, and it consists improvement in spontaneous bowel movements and stool consistency, quality of life, and it's sustained over 1 year. So, very little interaction with drugs. The drugs which we should avoid are bile acid preparation. Many of the patients are on ursodeoxycholic acid or other bile acids for various hepatocellular disorders, because what will it do? It will avoid their absorption, so there will be less effect of these bile acids on the liver disease. So if a patient is on UDCA, please avoid Elobixibat. And aluminium-containing antacids also decrease the absorption of Elobixibat. And similarly, cholestyramine, because it binds the bile acids, it decreases the effect of Elobixibat, because luminal bile acids will be then absorbed by the cholestyramine. And digoxin, dabigatran, and taxylate, their blood levels are increased. I don't know how they increase, but this is mentioned. And midazolam, this does decrease the effect of midazolam. Again, I don't know how that action comes into play. So, basically, this is a chart which shows that this is the relative absorption of various laxatives, lactulose. This is, our milk of magnesia, sodium picosulfate, prucalopride, and this is Elobixibat, which is the least absorption of all these. So, to conclude, dear friends, let me say that this is a summary slide from various laxatives. The osmotic laxatives obviously increase the volume and fluid excretion and absorption, and the PEG also does the same action. Sodium picosulfate also does the similar action. Prucalopride is a prokinetic for the colon. However, Elobixibat has dual action. It not only increases the fluid, it also increases the motility of the bowel, thereby has a dual action. And there is a very little drug-drug interaction. And see, the highest incident efficacy is 70% with the milk of magnesia, 72% with the polyethylene glycol in symptom improvement. However, the Elobixibat has 92% more than 3 spontaneous bowel movements, and over 2 weeks of treatment. So it's a very effective drug, and I think Mayank will be highlighting the studies and giving you more insight into it. And it has a good long-term safety up to 1 year. There is an established safety profile of this drug, but that will come out when we use it more often. So it has proven safety. Its efficacy is also now known, which you will be coming to know in shortly. And it has unique dual action, and it is a locally acting drug. And its safety is established in elderly and patients with comorbidities, because there's very little drug-drug interaction. And and phase 3 Indian studies, which Mayank will be alluding to, have shown that it is efficacious and it has flexible dosage, and we can make personalized dosing as per the patient's need. Thank you very much.
Thank you so much, sir. May I now request Dr. Mayank Kabrawala to kindly present his talk.
Yeah, sure. Good evening, everyone. Let me first share my slides. Is the slide visible?
Yes, sir.
Yeah. So thank you for this opportunity, and good evening, everyone. Dr. Sood has very extensively covered the management of chronic constipation, and this introduced to this new molecule Elobixibat. What my job is to share with you the trials which the clinical trials on the basis of which this molecule has come up. And as he already said that this molecule was licensed uh, to be used in Japan first, and so most of our studies are from Japan, and the studies and publications, they have the maximum information is from the Japanese studies. So first is the safety and efficacy of Elobixibat in chronic constipation. Uh, these were the two phase 3 studies published in Lancet in 2018. And the first study was a randomized double-blind placebo-controlled trial, 133 patients, and who met the Rome 3 criteria defining the chronic constipation. And it was a 2-week treatment period where 1:1 Elobixibat versus placebo were given to the patients. And the primary intention was to look for the change in frequency of SBM, or spontaneous bowel movements, and the BSFS, that is the Bristol Stool Formation Score. So the other study was an open label long-term safety trial where 340 patients in multiple clinics of Japan were included in the study, again meeting Rome 3 criteria. And it was for 1 year. It was mainly to assess the safety and the adverse effects of this drug. The doses were 5 milligram, 10 milligram, and capped at 15 milligram per day. So Elobixibat demonstrated fast and sustained relief. And this is what the study showed, that in about in about 86% of patients, the patients had first spontaneous bowel movements within 24 hours, and 46% had complete spontaneous bowel movements within 24 hours. The median time to the first bowel movement was 5 hours, and median time to the first complete CSBM, that is complete spontaneous bowel movement, was 9 hours. The frequency, so this bar diagram does show that the frequency in the first week and the second week as compared to the placebo was significantly more. This was around, the mean was 6.4, and here it was 5 in the second week. Again, this is for the CSBM, that is complete spontaneous bowel movements. Even on the long term, the one which was the open label trial, it looked at from the baseline, the spontaneous bowel movements had increased to significantly, statistically significantly, for till up to 52 weeks. Both the SBM and the CSBM, what we call as the spontaneous bowel movements and the complete spontaneous bowel movements. So compared to baseline, there was a statistically significant. Also, it looked at the improvement in bowel frequency and consistency. So as sir had said that it's usually on the Bristol score, and at week 1 and 2, the mean score was 4.3. Again, the proportion of the weekly responders of spontaneous bowel movements and CSBM increased and sustained through 2 weeks. So this is compared. This is at week 2, 54% versus 92%. And again, these studies did look at even the utilization of rescue medicines during the study. And here you can see within the first week, the need for rescue medicine like saline enemas, or maybe even the use of stimulants was much decreased even in the first week, and then much less in the second week after the use of Elobixibat. They had also looked, the same study had looked in the quality of life assessment. They have given a questionnaire which was in the Japanese language for the quality of life questions. And here they compared to baseline at 4 weeks, 12 weeks, 24 weeks, 36 and 52 weeks. There was significant, statistically significant improvement in the quality of life scores. The satisfaction scores were also calculated, and you can see here that these violet lines have progressively increased up to 52 weeks, and this was fairly satisfied and fully satisfied. Again, this was statistically significant all throughout as compared to the baseline. And looking at the safety, which was again a primary thing in the open label studies, and most of the adverse drug reactions was abdominal pain and diarrhea, which usually resolved in a couple of weeks. Of diarrhea, 60% resolved even without dosage changes, but 25% required reduction in the dose of the drug. And did not show any severe adverse effects, no deaths in the studies lasting up to 1 year, confirming its long-term safety. Elobixibat is primarily eliminated, as Sir has already alluded to that it is very locally acting. There is minimal absorption, and that is why excretion in the urine is very minimal. It acts mainly in the GI lumen, and the absorption is minimal, and that is why there is very minimal or low risk of systemic adverse events. Then coming to another, this was an interim analysis of post-marketing surveillance. After the marketing, it was post-marketing surveillance to evaluate the efficacy of this drug in elderly patients, specifically those more than 65 and 75. They are grouped two elderly groups, more than 65 and more than 75. And here they found that both at 2 weeks and 4 weeks, the bowel movements after treatment of Elobixibat, that was again much better at 2 weeks and 4 weeks as compared to the baseline, both in 65 and the above 75 groups. Even the stool consistency, that is the Bristol score, improved from the baseline to the second week and the fourth week in both the groups, 65 and the above 65 and above 75. Again, they also looked at the whether this elderly group of patients tolerated this medicine or not, and the incidence of side effects or the adverse reactions was less than 5%. It was around 4.46% in the group more than 65 and about 3.56 in the group above 75. And majority were diarrhea, abdominal pain, abdominal distension, and nausea. So fairly safe drug, and even in the elderly group of patients. This was one study which looked at what is called as the rectal sensory threshold. And above those patients above the age of 60 years, this was a prospective randomized double-blind placebo control trial conducted to investigate the effects of Elobixibat on the rectal sensory threshold in patients more than 60 years of age with chronic constipations. Now we know that there are three well-established sensory threshold. One is the FCSV, which is called first constant sensation volume. The second is DDV, which is defecatory desire volume, and the maximum tolerable volume. So they looked at before and after giving Elobixibat, and they found that participants who had reserved desire to defecate showed significant reduction in the DDV following Elobixibat. And in this other parameter, which is FCSV, there was significant or statistically significant reduction in the threshold where placebo did not. And again, in the third, the maximum tolerable value, there was also a trend towards improvement in the rectal sensory threshold. However, this was not statistically significant. So Elobixibat, then they had tried the use of this molecule and looked at the safety in other patients where associated comorbidities are present. And this is a entire chart about different studies in different groups: those with diabetes, those with renal disease, those with heart failure, cancer, and Parkinson's disease. These are the common conditions where you may need to treat patients for constipation. And here again, most of them, there is hardly any incidence of adverse events. There are incidents of diarrhea. There was good improvement in the quality of life score. The spontaneous bowel movements, as you see in all the groups, it went up to 6 per day. This is 1 per day, 6 per week, I'm sorry, 1 per day. 4 per week, 1 per day, and then 6 per week. So in majority of the comorbid conditions also, Elobixibat had done fairly well. Adverse events were also much less, except in this Parkinsonian, where majority the adverse effects was reported to be about 50%, and majority of it was diarrhea. So when this drug came, this group has been, this molecule was being tried in India. This was the phase 3 trial to evaluate the efficacy and safety of Elobixibat in Indian constipation patients. And this was a prospective, multicenter, randomized, double-blind, placebo-controlled trial. The primary objective again was to evaluate the efficacy of Elobixibat in Indian patients, safety and tolerability also. Again, the patients' inclusion criteria were chronic constipation for more than 6 months, and they satisfied the Rome 4 criteria for functional constipation. And the treatment duration was 2 weeks, where 1:1 Elobixibat versus placebo. Elobixibat was given in the dose of 10 milligram once a day, self-administered for 1 week. And in the second week, the daily dose could be adjusted according to the patient's symptoms, but the maximum cap was 15 milligram per day, and advised to take the study drug once daily in the morning before breakfast. And this is what the study did show in Indian patients: accelerates the spontaneous bowel movements in Indian patients. So the duration, the first spontaneous bowel movements was at 11.26 hours as compared to the placebo, which was much more, 22 hours. And during the first 24 hours, 51% patients on Elobixibat had spontaneous bowel movements, and only 37 patients with placebo had a spontaneous bowel movement. So found to be better. Again, Elobixibat increased the weekly spontaneous bowel movement frequency more than placebo. So this was a weekly score, 3.8 versus 2.7 in the placebo. And again, more patients achieved a complete SBM response as compared to placebo, 49% versus 27% in the placebo group. So Elobixibat outperforms placebo in enhancing the bowel movements in the Indian patients. Again, well tolerated even in our group of patients, the Indian patients. Around 150 patients were included, and the adverse events noted was in about 15.33% of patients. And most of the patients tolerated it well. 2.6% had dry mouth, 3.9% had around distension, around 8% had abdominal pain and diarrhea in 1.3% of patients. So nothing much to worry about even about the adverse, but as we know that this is a non-absorbable and a locally acting medicine, so a fairly safe and tolerable medicines even in the study from India. Now exploring Elobixibat with certain additional insights. So this was again a study from Japan where the dose escalation improves severity of constipation relief without increasing adverse reactions. And here they had divided into 3 groups: severe, very severe, and absolute constipation subgroups. And they found that the mean weekly increase of SBM and CSBM was comparable to the overall constipation cohort. And most patients in this group, those with severe constipation, titrated their dose to 15 milligram per day. And they continued with 15 milligram till probably the end of the trial. And there was obviously no notable increase in the incidence of adverse drug reactions after this dose escalation. So again, ensuring the safety and that higher dose required for patients who have a bad constipation, and the safety obviously is there. So another study, which is Elobixibat, well tolerated in daily doses oral. This was a randomized phase 2 study, which was to begin with, where they studied to estimate which was the best dose. So they found that when you change from 5 to 10 milligram, there was obviously improvement in the spontaneous bowel movements, but there was not much difference between 10 and 15 milligram patients. Something similar also in the this bar chart showing the patients with 10 and 15 milligrams had significantly higher rates of first SBM within 24 or 48 hours compared to those in the placebo group. So probably 10 milligram may be equally efficacious in majority of patients, but in those patients with very severe, you may go up to 15 milligram per day. So this was a study where they looked at what was the to assess the continuation of stimulant or saline laxatives during Elobixibat treatment in the real world setting. This was a real world setting. So they found that more than almost about 50% discontinued the stimulants or saline laxatives within 1 year after starting the Elobixibat. So this initiation of Elobixibat led to notably decrease in the stimulant and saline laxative prescriptions within a year, providing a valuable guidance for managing chronic constipation in the real world setting. Certain other features which have been found that it probably improves glucose and lipid metabolism. This was a single arm pilot study in 21 T2 diabetic patients having constipation, and giving this medicine for 12 weeks. They checked the HbA1c, which had improved from 7.8 to 7.6, and an LDL cholesterol decreased from 119 to 98. This probably again relation to the absorption of the bile acid. So these were, it has probably some potential in treating various aspects of metabolic syndrome also. We are not very sure about it. Then looking at its comparison with other available drugs, and this we don't have any head-to-head comparisons, and this is a newer method of how you compare various drugs. This is a network meta-analysis. The risk ratio of 1.27 suggested that Elobixibat might be more effective than prucalopride. So these are the comparative effectiveness. Elobixibat versus bisacodyl, almost similar. Elobixibat versus sodium picosulfate, similar, but probably Elobixibat scores over prucalopride here, and again almost similar with linaclotide. So Elobixibat, bisacodyl, and sodium picosulfate were found to be similarly effective for chronic idiopathic constipation, but bisacodyl, as we know, can cause a lot of cramps and diarrhea, which is probably has to be taken with a pinch of salt in bisacodyl and stimulant laxatives. This was again the same analysis, and I think I'll skip that. It is almost covered in the previous thing. Again, demonstrates the effectiveness outcomes, and the other method, which is NNT, which is the number of patients needed to treat to prevent one additional bad outcome. And this is the one other way to compare the various medicines, various drugs available in the patient in the management of chronic constipation. So here you look at it, the polyethylene glycol 2 NNT number needed to treat, lactulose 4, bisacodyl 4, linaclotide 5.6, prucalopride 6, 3.4. Elobixibat, the NNT was 3, which is a fairly good number. So Elobixibat is notably effective than most laxatives, with data showing that treating just 3 individuals can prevent one additional adverse outcome. So I think this is all we have, probably the data available with Elobixibat, and now as we use in our clinical practice, we'll be probably more familiar with these drugs, and probably we might be more in what group of patients this is helpful. Will be more what should I say? Will be more I'm sorry, aware about how to treat these patients. Thank you very much.
Thank you so much, sir. Due to some emergency, Dr. Sood had to leave the meeting. So we do have a few questions that I think Dr. Mayank will be the best to answer based on his experience with Elobixibat. So, sir, one of the question is, where exactly do we place Elobixibat in the treatment algorithm of chronic constipation?
Uh, So obviously we we will never use them in dyssynergic defecatory disorders, but patients who are having chronic idiopathic constipation and who have probably a slow transit or a normal transit constipation, they might be the group which might be best beneficial for this group. Probably we start with fibers to begin with, but this can be a drug which has been able to give a rapid relief to the patients and a sustained relief to the patients. So continuing, we have data for about 1 year from Japan, and probably it continues to have its effect. Like unlike some of the other laxatives which have a worn-off effect over a period of times, both with lactulose this happens, and even with picosulfate this happens.
Thank you, sir. One more thing is that it kind of has an effect on the intrahepatic circulation. So, how important will that be to the the normal intrahepatic circulation in the body? Will that have any effect, or is the effect negligible?
Yeah, I don't know. So far, 1 year studies haven't shown any significant problems associated with that. But yeah, looking at the mechanism of action of Elobixibat, this has probably to be kept in mind over a long time period, maybe over 4 or 5 years. When we use it, we probably will have a better idea. But so far, for 1 year, there's not much. And apart from that, I mean, Dr. Sood already had said that if the patient is on drugs like UDCA or aluminum compounds, or even the cholestyramine drugs which inhibit the bile acid, or they are bile acid sequestering agents. So these group of drugs has to be probably, we don't know about patients, their utilization in patients with cholestatic jaundice. We may probably learn over a period of time, but those are the things which may probably have to be kept in mind.
Thank you, sir. Dr. Chandrasekhar has asked if it is effective in IBS-C and what will be the duration of therapy in such patients.
So duration, we are not very sure still, but yes, IBS-C, it should be obviously helpful. And duration, so far, we know that till 1 year, we can continue with the medicine, but at least we can start with this medicine for at least 12 weeks or so, and then see how it goes about that. And it's only by, we'll be more aware about the its abilities, because it has a sustained relief. These patients can be benefited up to 1 year. So probably, I think to begin with around 12 weeks and then continue for long if required.
Dr. Kunal has put up a question like, because there is a bile acid involved, so how much of it will be in use for liver disorder patients? So hepatic disorder patients, how well will this drug act?
No, I don't think so. It has been tried in any of this disorders, but I think this may be something new only after some time. If we investigate this point, we may be aware about it. I mean, theoretically, thinking about it is right, but I think there's not any data about this.
I guess that were most of the questions, and the other questions have already been answered during the presentation. So, sir, before we close the session, based on your usage of the drug, we would just like you to give a closing remark to all of our viewers today.
Yeah, so I think constipation sometimes has been very challenging. And I think first of all, the diagnosis of constipation, I mean, what sir has already said, the chart, whether it's primary or secondary. And sometimes in the primary, you have very difficult to treat patients who are not responding to a lot of drugs. So probably this drug should be it has a dual mechanism of action, because it increases the motility as well as increases the secretion. So should have an edge over the other drugs used for the constipation. But essentially, I think only once we use it, we'll be more wiser about it. And so far, the data does show that probably is better than the most of the drugs, most of the available drugs. We don't have head-to-head trials for that, but the network meta-analysis does show that's a fairly good drug and scores above the other medicines. So I think thank you for this invitation, and it was a pleasure talking about this new molecule. And I congratulate Dr. Reddy's for introducing this in the market, and hope it's available soon and we'll be able to use it. Thank you.
Thank you so much, sir. Thank you so much. Thank you to the viewers. So I guess with Elobixibat, the future is gonna be bright and will be constipation free. Thank you so much for joining us on a Friday evening. Have a great weekend ahead. Thank you.